Good evening, everyone. Today we will be discussing a case. A 32-year-old male patient presented with chief complaints of left loin pain, difficulty in breathing, and abdominal discomfort since 2 months. He had history of palpitations, diaphoresis, and recently diagnosed as hypertensive 4 months back. On lab evaluation, his 24-hour urinary metanephrine levels and serum cortisol levels were elevated. Ultrasound was done. There is a large, ill-defined, lobulated, heterogeneously hypoechoic lesion with multiple cystic areas noted in left hypochondrial location, which is abutting the upper pole of left kidney. On CT, there is a large, lobulated, heterogeneous lesion with multiple ill-defined hypodense areas with a mean HO of 36 on non-contrast CT, showing post-contrast heterogeneous enhancement noted in left hypochondrial region in suprarenal location. The left adrenal gland is not visualized separately. This lesion is infiltrating the left renal vein and extending into the IVC. On MRI, there is a large lobulated T2 heterogeneously hyperintense lesion noted in left suprarenal location with no evidence of suppression on T2 fat-SAT sequence. So based upon the clinical history, lab parameters and imaging findings, my primary diagnosis is adrenocortical carcinoma as the lesion is very large, heterogeneous in appearance due to the presence of necrotic areas and its propensity to invade the adjacent vascular structures like renal vein and IVC. My other differentials includes pheochromocytoma, adrenal metastasis, adrenal adenoma and adrenal myelolipoma. Coming to the approach, first we have to look whether the lesion is adrenal in origin or whether it is originating from the structures adjacent to the adrenal gland such as pancreatic tail, liver and kidneys. To differentiate whether the lesion is arising from the adrenal gland or pancreatic tail, we have to look for the splenic vein displacement. In case of adrenal mass, the splenic vein is displaced anteriorly, whereas in case of pancreatic tail mass, the splenic vein is displaced posteriorly. Similarly, to differentiate between the hepatic masses and adrenal masses, we have to look for the IVC. In case of renal mass, a claw sign or beak sign is seen. After confirming the adrenal origin, we have to look whether the lesion is cystic in nature or solid in nature. In case of solid adrenal masses, we have to particularly concentrate on HU values on non-contrast CT. When there is presence of microscopic fat, that is density less than -30 HU, the diagnosis is myelolipoma. When the density is less than 10 HU on non-contrast CT, the diagnosis is lipid-rich adrenal adenoma. When the density is between 10 to 30 HU on non-contrast CT, it may be an adenoma or can be non-adenoma. For this, the next better step is to perform the chemical shift MRI imaging as it detects the presence of microscopic fat. If there is loss of signal on opposed phase images, then the diagnosis is lipid-rich adrenal adenoma. When the density is greater than 30 H on non-contrast CT, we have to perform the adrenal CT protocol. If absolute washout is greater than 60%, it suggests the diagnosis of lipid-poor adrenal adenoma. An absolute washout of less than 60% indicates the diagnosis of malignant lesions such as adrenocortical carcinoma, pheochromocytoma, and metastasis. Adrenal CT protocol includes non-contrast CT, portal venous phase taken at 60 to 70 seconds, and a delayed phase taken at 15 minutes. Both absolute washout and relative washout are calculated by using HU values in different phases. An absolute washout of greater than 60% and a relative washout of greater than 40% is highly suggestive of adrenal adenoma. Both lipid-rich and lipid-poor adrenal adenomas rapidly wash out contrast, whereas non-adenomas such as pheochromocytoma, adrenocortical carcinoma, and metastasis generally enhances rapidly but takes longer to wash out. MRI protocol includes chemical shift imaging for detection of intracellular microscopic fat, fat-SAT sequences for detection of macroscopic fat, T2 weighted sequences to look for the light bulb in pheochromocytoma, contrast study to look for the washout. DWA has no particular value in diagnosing the adrenal masses. So using the signal intensity on in and out phase images, adrenal to spleen ratio and signal intensity index were calculated. An adrenal to spleen ratio of less than 0.7 and signal intensity index of greater than 16.5% indicates the diagnosis of adenoma. Adrenocortical carcinoma is a highly malignant but rare primary neoplasm of the adrenal gland. It has bimodal age distribution seen in children and adults. It may present as functional or non-functional tumors, the non-functional tumors being the most common. It has heterogeneous appearance due to the presence of necrosis, hemorrhage, and calcifications. It has propensity to invade the adjacent vascular structures such as renal veins and IVC. It shows multifocal metastasis to the lymph nodes, liver, and bone. Pheochromocytoma is a rare catecholamine secreting tumor that originates from the chromophene cells of the adrenal medulla due to succinate dehydrogenase gene mutations. These tumors are said to follow a 10% rule, that is, 10% were malignant, 10% were bilateral, 10% were familial, 10% were extraadrenal, 10% occurred in children, 10% are not associated with hypertension, and 10% contains calcifications. We can't really differentiate between the benign and malignant pheochromocytomas. The only surest sign of the malignant pheochromocytoma is metastasis. These are usually large and heterogeneous due to necrotic, cystic, fatty degeneration and calcifications. It shows vivid enhancement in arterial and portal venous phases, that is greater than 110 to 120 HU. On MR spectroscopy, it shows a catecholamine peak at 6.8 ppm. Iodine 123 MIVG scan shows increased uptake, and biopsy is avoided due to hypertensive crisis in pheochromocytomas. On MRI, there is a large T2 heterogeneously hyperintense lesion in right suprarenal location with no evidence of loss of signal on opposed face images. Adrenal metastasis is the most common malignant tumor of the adrenal gland. The most common primaries includes carcinoma lung, bowel, breast and pancreas. So this is a known case of small cell carcinoma of lung showing right adrenal gland metastasis. FDG PET study shows increased uptake of both the primary lung mass and metastatic adrenal mass. Approach to incidentalomas. So what are incidentalomas? These are lesions seen in adults above 18 years old who are asymptomatic for adrenal pathology, referred for imaging for reasons unrelated to adrenal pathology, and on ultrasound, the size of the lesion is greater than 1 centimeter. If the patient had prior imaging done, we have to compare with the previous scans. If it is stable, then only follow-up is required. If it is a new lesion or if it is expanding, then the patient either undergoes surgery or PET CT. The typical benign adrenal masses includes lipid-rich adrenal adenoma, myelolipoma, cyst, benign calcified mass, and hemorrhage. No follow-up is required for these cases. Just reassure the patient. In cases of indeterminate adrenal masses, when the size of the lesion is less than 2 centimeters, then adrenal CT protocol is performed after 12 months. When the size of the lesion is 2 to 4 centimeters or the patient had history of carcinoma, adrenal CT protocol is performed immediately. An absolute washout of greater than 60% indicates the diagnosis of lipid poor adrenal adenoma and just requires the follow-up. An absolute washout of less than 60% indicates the diagnosis of malignancy and this patient undergoes surgery. When the size of the lesion is greater than 4 centimeters with no history of carcinoma, this patient undergoes resection. Or when the patient had history of carcinoma, then this patient is advised PET CT to look for the metastasis. Thank you all, and I would like to thank Dr. S. Naveen Kumar sir for giving me this opportunity through his channel Radvision SNK. And your passion for teaching and sharing knowledge is truly admirable, sir.